Well, it's a pleasure, but also daunting to introduce Nanette. She is a professor of medicine in the Division of Cardiology and also a consultant to the Emory Heart and Vascular Center. And I'm sure everyone here knows her, and in a sense, I could probably say nothing. I just thought I would go over a few of her recent honors and awards, just to give you an indication of who it is who's talking with us. She won the 1993 Outstanding Professional Achievement Award from Hunter College. In 1998, she was Physician of the Year Award from the American Heart Association. In 1999, the Distinguished Achievement Award from the Scientific Councils, the American Heart Association, and its Women in Cardiology Mentoring Award. In 2000, the James B. Bruce Memorial Award of the American College of Physicians for distinguished contributions in preventive medicine. In 2004, the Gold Heart Award, the highest award of the American Heart Association. In 2004, the Emory Williams Distinguished Teaching Award of the university and the Evangeline Papa George Alumni Teaching Award of the University School of Medicine. 2006, the Hatter Award, International Recognition for the Advancement of Cardiovascular Science. In 2009, the Georgia chapter of the American College of Cardiology Lifetime Achievement Award. 2011, she was selected as one of Emory's 175 makers of history, if you remember that, as we were celebrating our 175th anniversary. 2012, the Charles R. Hatcher Jr. MD Award for Excellence in Public Health from Emory University. 2013 Inaugural Distinguished Mentor Award at the American College of Cardiology. 2015 Inaugural Bernadine Healy Leadership in Women's CV Disease Distinguished Award from the American College of Cardiology. And probably most exceptional, in 2017, she won one of the Emeritus College Distinguished Faculty Awards. And I might say that initially there was a little bit of controversy about that, because some people were saying, I'm not sure she's eligible. I don't think she's retired. And yet people were saying, yes, she's retired. You just can't tell that she's retired. And finally, she's authored or co-authored over 1,500 scientific and review articles and book chapters. And when I see a number like that, what I can't believe is how anybody could read that many articles, much less write them. So it's really continues to be an amazing career, and thank you so much for coming, Nina.
It is always a delight to come to an emeritus college, because it seems as if the only time I can take off and get to one of the programs is when I'm speaking at it, because I still fortunately have both an active clinical and research practice at my clinical practice and research home, which is Grady Memorial Hospital. You know, there are those of us that love public hospitals and just go there and stay there. What I want to do for our conversation today is to address, is that working? Is to address two specific topics. First, to give you some idea of what has happened in terms of cardiovascular disease in women. Because as many of you know, for many years it was considered solely a man's disease. So we'll go over what the journey has been. And then we're going to switch gears, if you will, and talk about some of the important things that women, the women in your lives, your spouses, your mothers, your children, your siblings, your grandchildren perhaps, can do about their heart health. So two related but not contiguous topics. This is one of my favorite slides. Look at the bottom and look at the year. It's covered over by the, it's the 1990s. 1991. Yeah, we have studies of fruit flies, mice, hamsters, frogs, monkeys, and men with this condition. But medical research using women as subjects just never occurred to anybody. And for those in the healthcare field who remember the data from then, will realize that there were not women in any of the clinical research trials. Well, fortunately, that idea did recur and occur to somebody, and this is what happened. This is the 1990s. The men are represented in the solid line, the women in the dotted line. And you can see that all of the decline in cardiovascular mortality in the US occurred in populations of men, and virtually none among women. But then we began to get gender-specific data from research studies. And this is one of my favorite slides, and you will see it in almost every slide set I use. The men in the blue, the women in the red. And you will see that beginning in the year 2000, there was a precipitous decline in cardiovascular mortality among women, really more precipitous than among men. And in the year 2014, for the first time since these data were collected, there were fewer cardiovascular deaths in women than in men. And as I've said on other programs, we are delighted to be in second place, and we hope to stay there. But a word of worry, both for women and for men. You will see that over the last few years, mortality has actually increased among men and leveled off among women, with the change being predominantly in the younger population, 35 to 55. And the concern is that the lifestyle epidemic, sedentary lifestyle, obesity, and the resultant cardiovascular complications are fueling this. I want to show you some of the history. These are some of the things in my personal collection. This is a very early study that was a program that was done by the Oregon Heart Association about women and heart disease. And of course, what was the topic? Hearts and husbands. The women were told how to take care of their husbands. Look at the pictures there. They're all what should be done with their husbands to prevent heart disease among men. Not a few years later, this was the original presentation of the Heart Healthy Diet by the American Heart Association. And what is it called? It's called The Way to a Man's Heart. And this was typical of everything that was essentially sent to the general public and reinforced the concept that heart disease was a man's disease. This is a fascinating 1997 program that Dr. Harriet Dustin and I did talking about women and heart disease. But if you look at the bottom, you'll see what the time is. It's 11 p.m. We were the late show at that time. And rather than what we see today, where it's occupying center stage at midday. But that was sort of the history, and a lot of these are things that I've kept in my personal collection. Then the importance of advocacy. And I think this is what I want all of you to internalize for things that you believe in, because the communication that heart disease is a women's disease came from three major advocacy organizations. The first was the National Heart, Lung, and Blood Institute, the Heart Truth Campaign, with the message was that heart disease doesn't care what you wear. And the red dress was introduced as the symbol of heart disease in women. The same year, the American Heart Association, now 15 years ago, the Go Red for Women campaign, again, emphasizing heart disease in women, and the red dress became the symbol of heart disease in women. And now programs, red dress programs are being done around the world. I did one earlier this year at the European Society of Cardiology. We were supposed to have had a Go Red program at the Great Wall meeting that just concluded in China. But, and this is not a politically correct thing to say, but I'm going to say it nonetheless, it was canceled by the government. And the reason it was canceled is, you know, Go Red is a licensee of the American Heart Association. The licensee was the China Heart Foundation, which was perfectly well for decades. But it was licensed in Hong Kong. So everything that was licensed in Hong Kong was canceled. But the American Heart Association is very, very inventive. And while we were there, they opened an office in Beijing. They're going to be relicensed again in Beijing. And I promise that we're going to do one of these programs at the Great Wall next year. Then Women Heart, and this is a fascinating group. And these are women who are at risk for or survivors of heart disease. And this group was founded in 1999. They are advocates. They are on Capitol Hill every time there is an issue related to women. They have support groups in the community, and it is an enormously effective organization. So just remember, advocacy, a very, very important part of everything you have a passion for. I want to highlight just 2 or 3 steps on this journey that I see as having made a major difference. First is 2010, not that long ago. And this is the Institute of Medicine, now the National Academy of Medicine. And it was a report on women's health research, progress, pitfalls, and promise. And what it said was that medical research historically neglected the health needs of women. And I have called this bikini medicine because until that year, most of the research for women was done on the areas covered by the bikini bathing suit, the breasts and the reproductive system. And the rest of the woman, including the heart, was totally ignored. And then we define women's health as the sex differences, which are the biologic factors, and the gender differences that are affected by broader social, environmental, and community factors. But the IOM said there was major progress in reducing cardiovascular mortality, and I showed you those numbers. But they recommended more research on attention to quality of life issues, functionality, mobility, wellness. And any of you who are in the healthcare sciences will realize that when you look at the outcomes of randomized clinical trials, no one ever looks at quality of life, functionality, mobility, and wellness. They're all related to morbidity and mortality. So we need to increase our spectrum of what we're looking at for women's health in general and women's heart health. And this IOM report further taught us something extremely important. And that is that women are not a homogeneous group. There are disparities in disease burden among subgroups of women, particularly those that are socially disadvantaged because of race, ethnicity, income, education, etc. And recommended to the research organizations targeted research on women with the highest risks and burdens of disease. And then to many of us as journal editors, the lack of analysis and reporting of sex-stratified analysis limit the ability to identify potentially important sex and gender differences, including differences in care. And said to journal editors, and you've all been involved with what journal editors are supposed to do, should require clinical trial outcomes to be presented separately for women and for men. And actually a number of journals are now doing it. And then translation of findings into clinical practice and public health policies, and then communication of the research-based health messages to women, to the public, to providers, and policymakers. And you're all included in one or more of those categories. And I think that the progress in terms of women's heart health has been very much like that of Sisyphus, pushing the boulder up the mountain only to have it return to the base again. But I think we have received some very important contemporary help for Sisyphus. This is not working. It does, okay. And what is the state of the science? And we're now beginning to partner the cardiologists with the obstetricians and gynecologists. Because as you know, most young women who don't have disease receive their primary care from the OBGYN as a primary care physician. And you know, the OBGYNs are in a preventive mode. They do mammograms, they do pap smears, but what this is saying is that they should be doing preventive measures for the primary morbidity and mortality among women, which is heart disease. And what was defined in this paper, which just came out last year, was that 90% of women in this country have at least one risk factor for cardiovascular disease, but women are less likely to receive guideline recommended diagnostic testing and therapies. And that healthy lifestyles and behaviors for cardiovascular should be discussed at each OBGYN visit. Screening for cardiovascular disease and cardiovascular risk factors should be enhanced. And then this shared information should be used to assess risk, initiate interventions, and facilitate significant lifestyle changes. And we're starting to work with ACOG, the Association of OBGYN Physicians, to get this implemented in their clinical practice metrics, because that's not done. And then this is the game changer. And this is the Heart Research for All Act of 2015 that shows that at times our Congress is capable of doing things that are positive from both sides of the aisle. Introduced in April 2015, previously the two government agencies involving research and practice were the National Institutes of Health and the FDA. And they had issued guidances and recommendations over the decades. And a guidance or a recommendation, as well you know, allows people either to follow it if that's their choice or to ignore it. And generally it was ignored. But this was now a mandate by the Government Accountability Office to update reports on women and minority inclusion in medical research, both at the NIH and at the FDA. The NIH, this related both to clinical trials and to basic research to ensure that both male and female cells, tissues, or animals were included in basic research. And not that many years ago, when I would ask a basic researcher the provenance of their cells or their tissues, they had no idea whether it came from a male animal or a female animal. Much of this research was done in mice or rats, and male mice are cheaper than female mice. So likely, most of this was being done in male mice. And female diseases were being studied in cells, tissues, or even male animals. Now the world has changed, and this has to appear on every one of the grants. Otherwise, it automatically gets triaged to not even being looked at. And that the results have to be disaggregated according to sex and sex differences examined, and then update guidelines on the inclusion of women and minorities in clinical research. And as I sit on study sections, the most delightful thing I see is that there had to be retraining of the NIH project officers, of the section chiefs, et cetera, because this is a deal breaker. If you don't have information on the inclusion of women and minorities and a plan for how you're going to recruit, what you do if there's under recruitment, that's an automatic triage out of your research grant. And now for the younger investigators coming along, since 2015, this is routine. It's going to be a decade until those studies are implemented and we begin to get data, but it is happening. And then, you know, the FDA certainly doesn't conduct independent research, but if you were industry for a drug or a device going to the FDA, there's usually a pre-trial discussion, which says by industry, if this drug or this device is studied with this protocol and we have positive results,
is it likely to be approved? And at that pre-trial stage, the FDA can recommend or intervene. And now they have to say, if this is a device or drug that is going to be used on women, there have to be a representative number of women and minorities in that trial, or that trial will not fly. So again, it will probably be a decade until the new trials accept this now mandate, not a recommendation, not a guideline, but a mandate. And I think we will see data on women. And only recently have there been a few reports coming out, mainly from Europe, where the ESC did this a little bit in advance, showing that some of the drug doses should be different for women than for men. But typically, even going back into the trials, there were not enough women in the trials to say, did drug dosage make a difference? So we will have data, and we will have data specific for the care of women. And as I've told the audiences, I think that as we approach the steps on the journey to improve outcomes for heart disease in women, certainly the first is investigate, get the research data. The second is educate women and educate the providers. Then advocate based on this. But possibly in many arenas, what has to be done is legislate, because this legislation has made a difference. But these are my thoughts. And I expect that the landscape of women's cardiovascular health research has to be expanded, because women's cardiovascular health is not solely a medical issue. And I think we have to look at beliefs and behaviors, at community effects, locally, nationally, and globally, at economic influences, at environmental influences, at ethical issues, at legislative and political issues, at public policy, and societal and socio-cultural issues. And I think we may even begin to see some of these looks on the Emory campus, because President Stirk's challenge, as we now have very women's health and sex and gender differences, sizable and impressive national research grants, is to say, are we looking at sex and gender differences across the schools of the university, not solely in the healthcare schools? And I'm on a committee that is going to be looking at some of these issues to say, what do we have to learn from the non-healthcare science arena about the importance of sex and gender differences? Because that surface has rarely been scratched. And I think we will find some very enthusiastic investigators and some very enthusiastic ideas for investigation. Okay, that's why I think it's important to look at gender differences in cardiovascular disease. Now, as my transition, who are these two people? Come on, what happened to your classical education? Well, no, the gentleman is Aesculapius, who is the god of medicine, and to his side is Hygeia, who is the goddess of women's health. Now, the Greeks had it all set. Hygeia took care of the women and their women's health, and they didn't have to bother doing anything. But now that we don't have Hygeia to help us, what do we have to do? And that was sort of the basis in the transition to talking about Show Your Heart You Care, and talking a little bit about contemporary guidelines and information for the prevention of cardiovascular disease in women. This is something I put together a number of years ago, and I've updated it, and I've used it for another program, but I thought it was important to share. Obviously, there's a persisting magnitude of the problem of cardiovascular disease in women. And more women die from cardiovascular disease than cancer, respiratory disease, Alzheimer's, and accidents combined. And as I suggested earlier, cardiovascular death rates in the younger women in this country are increasing, reversing the benefits of the past 4 decades, likely related at least in part to an obesity epidemic, but I think sedentary lifestyle plays a great deal of role. And one of the experts in this area, Earl Ford, who's referenced here, called this the leading edge of a brewing storm. And I think what it means is there's going to be full employment for cardiologists for many years to come. Important to realize is that the adverse mortality and morbidity actually in Black women is far greater than that in white women, and it parallels the lack of awareness data among minority ethnicity and racial groups among women. And what I tried to do is to put together an owner's manual for the heart. You know, we have owner's manuals for our cars, we have owner's manuals for our dishwashers. We don't have an owner's manual for our heart. And I tried to put this thing together, the first being the technical specifications. What are the parts and what are the features? It's a muscular pump, a little larger than a clenched fist. It weighs less than a pound. It beats over 100,000 times a day. It's a hard-working pump. It pumps 2,000 gallons of blood every day, and that's nearly 5 quarts of blood each minute. It has some, 60,000 miles of arteries, capillaries, and veins. And the warranty, if you take care of it as described, is on average 81 years for a white woman and 76, 77 years for a Black woman, if you read the owner's manual carefully for the operating instructions. And the care and maintenance, the concepts for the owner, you own your heart, is empowering women through awareness and education that favorable lifestyle changes can lessen cardiovascular risk factors and prevent cardiovascular and coronary disease, but that there is a continuum of risk. So you have to match the intensity of the intervention to the risk. But the underlying message is that behavioral changes by women and the reshaping of practice patterns by the healthcare providers to provide sex-specific data can dramatically decrease the number of women who are disabled and killed by cardiovascular disease. And that this is a partnership. It's a partnership between women and their healthcare providers. And the directions for operation are very recent. This is a 2019 American College of Cardiology, American Heart Association guidelines for the primary prevention of cardiovascular disease. What is it that you should do if you are healthy? And that's sort of the basic reference. And then there is a score that's being used. And one of the things you should do when you see your provider is to say, what is your risk score? This is gender specific. It's specific for Caucasians, for African Americans, a little bit less reliable for Hispanics and Asians because of the population that this is based on. But all of the things that your healthcare provider has should go into this score, and they should be able to tell you whether you're at high, medium, or low risk for cardiovascular disease. And of course, that guides the intensity of the intervention. But the preventive approaches, the operating and maintenance instructions, are that the major initial emphasis on primary prevention is lifestyle. And you know, I always think of a quote from one of my teachers, who was Dr. William Cannell, who was the founder of the Framingham Heart Study. And Bill, we were saying, why is it that physicians don't like to spend time talking about lifestyle? And he said, you know, in this short visit, which over the decades has gotten shorter and shorter and shorter, physicians hesitate to spend part of that visit telling them what their mother-in-law would have told them for free. And I think what we have to do is that as clinicians, take back that mother-in-law role and spend time on lifestyle interventions. And then there are obviously, if major risk factors are identified, specific interventions, and I'm not even going to discuss drugs, but this is the hierarchy. The first preventive intervention and the major emphasis is lifestyle. And then there are a few interesting facts that I think reinforce some of these recommendations. People who quit smoking before age 50 have half the risk of dying over the next 15 years compared with those who continue to smoke. Smoking cessation improves lung function 20 to 30% within 2 to 3 months, and this is objective measure. After a year of smoking abstinence, the risk of coronary disease is reduced by 50%, and within 5 to 15 years, the risk of stroke is similar to someone who's never smoked. So short-term and long-term benefits. And then this was done specifically for women. Most of this applies to men, although the data are not as good. Walking cuts women's heart disease risk, and these are studies conducted in women. In the Nurses' Health Study, looking at some 70,000 women 40 to 65 years of age, and remember 65, that was a time when no one who was older was included in clinical research. 65 was the upper limit. Vigorous exercise and brisk walking reduced the risk of heart attack or coronary death by 30 to 40%. This is all self-reported. Women who were sedentary, but later engaged in moderate walking reduced the risk of heart attack and coronary death by 20 to 30%. And walking at a slower pace was also beneficial. And then this is Wenger's 250-250 rule regarding weight control. Exercise an extra 250 calories a day. You can get what kind of exercise and the duration anywhere on your phone. Eat 250 fewer calories per day. Now that's 500 fewer calories per day, 3,500 fewer calories a week, and that equates to a pound of weight loss. Very simple calculation. And then the fact that lifestyle changes work. What would you do if someone could tell you you could reduce the risk of getting type 2 diabetes by 58%? Well, this is what happened in the diabetes prevention program. Diet and exercise effectively delayed diabetes in a diverse American population of overweight people with impaired glucose tolerance. And that was physical activity for just 30 minutes a day and a weight loss of only 5 to 7% of body weight. It's an old study, but the data still hold up. And then class 3 intervention in clinical trials and clinical reporting means don't use it, no benefit and potential harm. And basically it says menopausal hormone therapy has no role in cardiovascular disease prevention, nor do antioxidant supplements. And the interesting feature I found was having my women patients get rid of the antioxidant supplements. They love their vitamin E and C and beta carotene, and we're using that and not using the guideline-directed preventive therapies. So that was a lot of work in terms of what I was doing in my clinic. And here is the owner's manual for checkups and maintenance, and you have that on your list. And these are risk enhancers, because what if your doctor does your ASCVD risk score? If it's low, you're fine, say what you're doing. If it's high, there are a lot of things that have to be done. But what if you're intermediate? Are there things that will get you closer to the low or closer than the high? And family history of premature disease. So certainly your provider should know if you have a family history of heart disease. Persistently elevated LDL, the bad cholesterol, over 190. Likely that's familial, and you may want to suggest that your family members be tested. Chronic kidney disease, metabolic syndrome, and then some conditions specific to women. And here is where we have a problem with our electronic health records, because there's a complete separation of a pregnancy history and the rest of the medical history. And I always tell my women patients, bring your pregnancy history to your primary care provider if it's not your OBGYN. Because typically on the electronic medical record, all that's listed is the number of pregnancies and the number of live births, nothing else. And all of the data regarding complications are missed. And we're coming to realize that the complications of pregnancy, hypertensive disorders, preeclampsia, and actually small for gestational age, babies and preterm delivery are all powerful predictors of future cardiovascular disease. And this is particularly important, obviously, in the younger women. And they should know if they're at risk. We currently at the Emory Women's Heart Center have a cardiologist in the OBGYN department in the 6-week visit for patients who've had preeclampsia, where they introduce themselves to the patients, where they are. If they have risk factors, they address them. If not, they tell them you've got to get rid of your pregnancy weight, continue not smoking, physical activity, etc. So this is something that we're doing actively here at Emory. Inflammatory disease, and many of these, such as rheumatoid arthritis and lupus, predominate in women. And that will increase the risk. And ethnicity, such as South Asian, Hispanic, and African American, much more at risk than a Caucasian. Something we're looking at newly in the lipid, and that's elevated triglycerides over 175, elevated, what do I have there? C-reactive protein, and marker of inflammation, elevated Lp(a), which can be measured only once in a lifetime, doesn't have to be measured serially, and that may impart increased risk, and ankle brachial index, which measures leg blood flow. I think what I've done is to show you that heart disease in women can be an equal opportunity killer, but that there is something that you can do if you take your owner's manual and follow it. I thank you for your attention, and I'll address any concerns or questions or challenges.
The ASCDD risk assessment that you showed the form, is that online?
Yes.
Can a person do that on their own? Without
If you know your numbers, yes. It has numbers you have to put in about blood pressure, cholesterol, et cetera, but that you should have from the summary of your medical record. Yeah.
So it's online?
It's online, yes.
I want you to notice I'm getting some exercise.
Very good. We'll count the steps.
A great talk, and we've been together, not related, but we had women in common. What
Speaking
happened at Grady Hospital was that we were, for one thing, seeing abused women and abused children. Through the child, we got to the woman, from the woman to the man, with sexually transmitted diseases. So we got the grants in 1970s, 80s, 90s, because we got to the child and the woman from the man with sexually transmitted diseases. And what we found was that a lot of things, but we should have tied up with her on the heart, but we tied up with the OBGYN like Bill Josie's and others. Other thing I want to say to people who may not appreciate it is how much research and medical help has been given at Grady. We both are Grady kids. I mean, I've been there for 55 years and she was 60. And people don't appreciate what we did for the population, the community. For until 1990, there was no interest by Emory of the community except at Grady. And then they got into other community things. So I just want to stress how important what she mentioned, and also to say, for instance, infectious diseases like AIDS that we got into with big grants and so on, were showing that the young women were twice as likely to get the AIDS than the men. They were 15 or 6 or whatever, and that. So there's a lot of commonality, and I'm sorry that we didn't get together more.
In the current issue of Atlanta Medicine, there is an article that Alan Dollar and I did about the history of cardiology at Grady, if you want to look that up online.
Would you talk a little bit about the pie chart that you have on this handout?
Yeah, well,
And the letters that are assigned? That's one question. The second question is, did you talk specifically about aspirin?
okay. Well, you know, aspirin is a changing scene, and the changing scene is yes, no, and maybe. Early on, the studies for aspirin were done in populations of men, and aspirin was shown to prevent heart attack, but not stroke. Then in the women's studies, aspirin was shown to prevent stroke, but not heart attack. So aspirin, except over age 65. This was all below age 65. Then more recently is the last couple of years, the evidence with contemporary therapies and contemporary prevention, which is very different when those guidelines came out, suggested that for individuals, both men and women, at low risk, again, importance of the risk score, that aspirin does not provide benefit over the risk of increased bleeding. And I think people underestimate the increased risk of bleeding with aspirin. For high-risk individuals, certainly aspirin, the benefits of aspirin, cardiovascular disease and stroke, are greater than the risks of bleeding. In the intermediate group, this is where I think you and your providers should be looking at these series of modifiers and say, are you more like the low risk? Are you more like the high risk? And that's where the decision for aspirin comes in. But it's not everybody gets an aspirin. Now, if you have heart disease or stroke, that's secondary prevention, absolutely. Low dose aspirin every day. If you think you're having a heart attack, a full dose aspirin chewed on your way to the hospital.
What about the pie chart?
What about the pie charts? Let me get my crib notes and see what your questions are about the pie charts.
You have letters assigned to each section. And I wonder what
Oh, no, A is for aspirin, B is for blood pressure, C is for cholesterol, C is for cigarettes, D is for diet, D is for diabetes, and E is for exercise.
I thought it was a hierarchy.
No. But these are the general recommendations, and then these are the risk modifiers. And I thought it was much easier to hand it to you than to have you bother scribbling it down.
Nanette, thank you for this talk. Could you explain a little bit about the difference between African Americans and whites, and what approach is being taken to lessen that difference?
How many hours do we have?
Go for it.
Yeah, no, I think probably it is more environmental than genetic. The genetic differences don't seem to explain it. A lot of it is socioeconomic status. A lot of it is the prevalence of risk factors. In the Atlanta area, your zip code is as good as the risk factors in predicting your risk. So we can just see major differences by zip code and everything that the zip code encompasses. What's being done? Education.
Where does hypertension fit in?
It's one of the major coronary risk factors.
hypertension, diabetes, cholesterol, sedentary lifestyle, etc., obesity, cigarette smoking.
Is there any consensus as to whether so-called moderate alcohol use is a risk or a benefit?
I think moderate alcohol use is neutral, but that is 1 drink a day for women, 2 drinks a day for men, and I don't mean drinks this size. But, you know, when I first came south, my patients had to educate me because one of the gentlemen I saw in one of my first clinics was asking how much he could drink. I was thinking about a shot glass, and his wife took me out in the hall and said, he's talking about this. So it's your metrics. David?
The young people, I was surprised about the statistics of that heart disease is growing in young people, because the young people that I run across are exercise freaks. I mean, they're out, they're running every day, or they're bicycling for miles and miles, and so on and so forth. It's true that most of the young couples I know are in multi-job families, and they've still got children, so there's a certain amount of tension which is there. Could you comment a little bit on this, whether this exercise and diet, I mean, a lot of these people are vegan, and there are all kinds of vegan that you can be. They're much more attentive to their diet and to their exercise than folks I knew in our generation.
But what you have to remember is that both you and I live in very rarefied societies. And when I look at the people who are friends of mine, friends of my children's, et cetera, they are totally different young population than the patients I see at Grady. So we're looking at a small subset of the population that exercises regularly and that has a relatively healthy lifestyle. Likely they don't smoke, likely they're not overweight, et cetera. Likely they're not diabetic, so that it's a very small part of the population. When you do it by zip code, you will see major differences just in our city. And some of the people that are looking at the social determinants of health are looking at that very, very carefully. Because there's some zip codes where you can't walk or ride outside safely, ride a bicycle. There are some zip codes where there is no food available, the fruit deserts in Atlanta. We're trying to intervene, but that is not going as extensively as it should.
Helen, could you pass this down?
Question from Spencer is one I always dread.
No, and that was great, by the way. Do you want, since the calcium scan has been elevated in the guidelines, I wonder if you want to comment on intermediate risk patients and what that might be in deciding whether to intensify the investigation or intensify the therapy.
Well, again, I think that the challenge to your physician and you will be if you're in that intermediate risk. If there's a risk modifier, that may help move you. But all of these are partnership decisions. And this is something that you and your physician discuss the benefits and discuss the risks. And this concept of shared decision-making is something that is relatively new in medicine. It's something that should always be done. And if your provider suggests something, you have to say, what are the risks? What are the benefits? What is the status of doing nothing, which is another option? And together with your provider, make a decision. Now, this is a new phrase to many people. And I will tell a tale out of school because I was invited to a group which will remain unknown to present the concept of shared decision-making to a group of surgeons. You can tell I came to that meeting late, and that's why I got that assignment. But I presented this to the group of surgeons who probably nap most of the time. And after I finished, one of the senior surgeons from the back of the room stood up and said, "Nanette, this is nothing new. I've been doing this all my life. What I do is I decide what's best for my patient, and I share it with my patient."
Maybe shared decision making could be also applied to government. A new concept.
John, did you want?
A lot of emphasis has been put on cholesterol
Hold it up to your mouth.
in the prevention of heart disease. And I'm wondering if it would make sense for patients to try to get their cholesterol level as low as possible, rather than always using this guideline of a threshold above which it's a problem, below which it's maybe not a problem. Should the goal be to get everybody's cholesterol absolutely, the LDL level absolutely as low as possible?
Well, the studies of the very powerful new medications show that there is no level too low, and there seems to be benefit. But again, what we are examining is cost versus benefit. And if we know that for people with disease, we want the LDL below 70. If I can get it lower and the patient can do it, can afford it, et cetera, that's fine. For the general population, I'm pretty happy with an LDL of 100. But the data of decrease in mortality relate very prominently to the widespread use of statin therapy. But statin therapy is not without side effects. But a low cholesterol is not an adverse effect. But we have to get together with the Society of Clinical and Laboratory Pathologists. Because if you get your lab data back, as you do on your patient portal, and you have a cholesterol where I think you should be, it's listed as low rather than where we want it to be. And as long as that happens, the lab reports are undermining what we do in clinical practice.
What do you mean? What do you mean? You just said 100 was okay.
Yeah, but the point of it is that if you're below 100, it tells you that you're low, instead of you're doing even better than normal.
Well, the thing, I think people miss, I don't know if people would agree to take this poll, but how many people here know their LDL cholesterol? You know the number?
I mean, not my heart.
Yeah, that's good. It's changed a lot, because it used to be, all the doctors said, your cholesterol is okay.
Right.
Your blood pressure is fine. And you ask patients, well, what is it? Well, I don't know. He told me it was okay. So my advice is never accept that answer. Get your actual values.
Does the
So you
patient,
know.
does the patient portal distinguish between men and women?
That's interesting.
No, the patient portal,
The patient portal
the patient portal is your specific health record. The ASCVD risk score has a separate component, men and women, yes. And separate component, you check off the boxes for Caucasians, for Blacks, Hispanics, and Asians. The patient portal is your permanent health record, yours.
And the ASCVD
Risk score it's a score that should be on your patient portal. And if it's not, ask your provider why not.
And since one checks off gender, then it'll automatically calculate that.
No, other things have to go into the score.
Yeah, I guess so.
Yeah.
This is not really a question, but hopefully a very brief comment. I was certainly aware of this 2015 regulation, I guess, from NIH about grant applications have to show that subjects will span genders, race, ethnicity, et cetera, et cetera. So I think that's a good idea. It does, that regulation though, does present some statistical issues. And so one thing is that just because you have, you know, a few women in your sample or a few, you know, African Americans in your sample or a few, you know, Asian Americans, et cetera, you can sort of, you know, analyze race, ethnicity at different levels. But the statistical power to sort of see that whether there are differences there may be very poor. And so if you, it might be easy for some people to say, oh, there's no difference between these two race ethnicity. So beware of that.
Very, very important. And that's the reason that the people who review the grants have to ensure that there's adequate representation and that there's a plan in the grant somewhere along the recruitment phase to say, what are you going to do? For example, one that I know about intimately because I chair the DSMB, and this is Joanne Manson's trial on vitamin D and omega-3 fatty acids. And they, particularly for the vitamin D, they knew they had to have a good representation of African Americans. And therefore, once one cell was filled, they closed it and they recruited only to be able to get the subsets that they needed. So there are, and that's what the grant reviewers are looking at and in the proposal of if you've not met the diversity, what are you going to do? And if you don't have a plan, you don't get funded.
As I say, I think that's good. And and just a second point, if you go into statistical modeling where the dependent variable is something like I will get cardiovascular disease or something like that, you really need to put, in addition to main effects in the model, a statistical interaction, say, between a risk factor and gender. That makes the model a little more difficult to interpret, but if you can't do it yourself, see your friendly statistician.
Which we now always do because none of us have, oh, no, let me check, few of us have these skills.
And Andy's got a question, and then I think we can probably wrap it up and invite people to come forward.
It's a burning issue. Many of the things that you mentioned related to the heart problems is also with Alzheimer. What connection now is there? Are there studies that show that if you have problems with the heart, you have more Alzheimer or vice versa?
You have more what?
Alzheimer disease.
Yeah, the Alzheimer data are not that clean because it's a disease of older age. I'm not talking about the early onset Alzheimer's, very different. But it's a disease of older age, and most people have comorbidities. But you can't specifically tie that because everyone knows individuals who have relatively good health and who develop Alzheimer's. So the coexistence of the diseases doesn't mean causative or protective.
So how about a big round of applause?